us on this Waterlase webinar, Perio 101 Laser Crown and Lengthening. This is going to be hosted by Dr. Preety Desai. Thank you very much for doing this for us all the way from Canada. Dr. Desai is an awesome speaker and she does great with our lasers. She does a lot of in-office trainings, lots of webinars, lots of everything. So want to say thank you to Dr. Desai for doing this for us. Without further ado, Dr. Desai, the panel is all yours.
Thank you so much, Javier. Thanks all for joining me on a Thursday evening. It's just after work today for me, but I do appreciate it. A little bit about myself. I'm a board certified periodontist. I've been practicing for about 30 years and can't believe it's that long. And for the last 20 years, I've been basically exclusively using the Waterlase for the majority of my procedures. I can definitely say I rarely pick up a scalpel and a handpiece these days. Not 100%, but the go-to piece of equipment in my office is my Waterlase. I live quite close to the Rockies, as you can see here. So come visit me. This is beautiful Mount Assiniboine. And it's not also too far from the University of British Columbia, where I have the privilege of teaching in the undergrad and graduate programs there. So I'll keep up my academic and interests, and also to keep in touch with the new graduates and see what their mindset is, which is very interesting because things have evolved since I have graduated for sure. My charge today is to discuss the specific part of my specialty, which is crown lengthening. And I want to bring a little bit of that old philosophy of trying to save a tooth for restorative purposes so that the patient doesn't lose their dentition, and bring in the new, which is adapting the laser to producing the results that I consistently am able to see over the years. Now, it's very interesting because on the clinic floor at school, I find that this option and treatment plan is being suggested to patients less and less. And it's very interesting as things shift into the implant world, where it just seems to be the go-to quick and dirty to say, yeah, don't worry about saving a tooth like this, which is fractured. We're just going to take it out and put an implant in. And I may be being a little bit facetious, but saying that we read things like this in the editorial pieces and public opinion things on social media and regular media, where we have people writing negative things about dentistry, and then you see something like this where there is a little bit of ridicule about what is surrounding the full-on implant world that we're facing today. I can tell you, and you as experienced clinicians know, that implants are not the be-all and the end-all. They are not superheroes, and more so, the graduates that we're graduating today are going to be facing a whole schwack and slew of periimplantitis related issues. So the title of some of my lectures today is facetiously also called Give Teeth a Chance. So I hope I have something important to share with you today, and hope you can take away a couple nuggets of information as a result of that. So in dentistry, we have classified crown lengthening as twofold. Number one, called aesthetic crown lengthening, which is all about smile design and setting up a beautiful gingival foundation in order to place veneers, crowns, even out the gingival profile, dealing with a gummy smile, the gingival overgrowth, altered passive eruption, all that kind of stuff. There are a bunch of excellent speakers speaking on this, and it is a very multifactorial topic, and we are not going to be talking about this today. What I would like to just address very, very simply is the functional crown lengthening, the ability of a patient to save a tooth that has been damaged, traumatized, has caries, etc. And the definition of functional crown lengthening, which does occur in the anterior as well, you can break front teeth, is that we want to set up the foundation so that the restorative dentist is able to complete all the work in order to have a long-lasting, retentive, restorative option for the patient. And the outline for today is quite simply much like in the outline that was presented online, is that number one, we're going to go over some very simple terminology, anatomy, and definitions so that we're all on the same page. Secondly, I'd like to talk about very simply the indications for crown lengthening, the goals and the risk factors that we face in order to have a very predictable result for the patient. Third, I'd like to talk about alternatives to treatment, and we already touched on that about implants and extraction, but then jumping over that to the meat and potatoes of today's talk is comparing traditional techniques that I was trained in, my colleagues were trained in, versus the way I have adapted, morphed, and changed things in my practice to benefit the patient, to supply an alternative in a minimally invasive surgical field. And finally, we're going to walk through one case that I did about 2 weeks ago from beginning to end about the step-by-step. If you have a Waterlase in your office, you can basically write down these steps, and it's like a ABC of how to get the results that you should expect with a laser crown lengthening. So let's start with part one. Basic terminology and the history of crown lengthening. In Perio, we're famous for looking at the literature and being ground down and memorized all these papers from the 40s, 50s, and 60s. And it was in 1962 that Cohen wrote a paper on just that, crown lengthening. But there was a mindset even back in that era to maintain the quantity and the volume of the keratinized tissue. We were aware even back then how critical that keratinized tissue was in order to have longevity with teeth, and now, of course, with implants as well. Everyone has also, I'm sure, heard about Gargiulo and his famous biologic width dimension. In essence, the paper in 61 that was presented was showing us that connective tissue plus junctional epithelium, that dimension around the collar of any tooth, is considered the biologic width. Basically, it is the social distancing that the bone needs to be away from the tooth, CEJ, or the restorative options that the patient has. If we do not have a total plesicellular epithelium of about average 3 millimeters, then somebody is unhappy. And usually it is the alveolar supporting structure, and then the secondary reaction is the soft tissues. Now, 3 millimeters is an average. A paper done, what is it, 60 years ago, is certainly, to be taken with a little bit of, I wouldn't say a grain of salt, but as we have moved into a more scientific and advanced field, we understand that this is not a law of just averages. There's many different variables. We now are aware of gingival phenotype, whether it is a thick or a thin, or even just a modest in-between type. We know that this is an average. Thick phenotype actually needs a larger biological width, and thinner phenotype may actually need a thinner biologic width. So these are average numbers. Thirdly, we must remember that the tooth is three-dimensional. How many cases that I have seen in the aesthetic zone where restorative was done soon after gingivectomy or just flopless osseous curettage, or Wedelstating alveolar bone away in only one dimension to result in inflammation of the whole area because the three-dimensional aspect of the tooth was not taken into account. I know these are simple things, and it seems almost silly to be beating that detail down, but it will come to play when we talk about risk factors in considering which tooth and which teeth are to be crown lengthened versus not. We used to, in the World Workshops, we wanted to call this supracrestal attachment in 2017, but it never really took hold. But that is indeed the terminology we would like to use instead of biologic with. So just a little aside there. The definition of feral. The first paper on feral came out in 61. And in those days, we had different restorative guidelines, and no longer today is 1 or 2 millimeter feral adequate, but it is that 360-degree retentive aspect of a crown that will create retention and protection of a crown that we're going to be placing for the patient. And ironically enough, it has come obviously from the Latin term ferrum, which is iron, and virolia, which is bracelet, which is of course at 360 degrees. So just a little trivial pursuit question. Today, our ferrule obviously has to do with the longer it is, the better. Some papers have suggested minimum 4.5 millimeters for the crown prep and for a full-on retention. So, this is what our standard is today, obviously. So when we talk about a tooth that is compromised, it can be compromised for a number of reasons, but our goal at the end of the day is a retentive crown, let's just say full coverage for the patient that is worth their time, their money, and the longevity of what is the guarantee. And that is always the question that I get in the office going, Preety, are you sure? Maybe we should just do an implant and get it over with. And so it's almost like, the Vegas betting odds as to how long will a tooth last. Let's put some data behind it and, maybe do some more up-to-date studies on, crown versus implant in the same mouth, split mouth design, et cetera. But at this point, a lot of it is experience, data from the past, and judgment of that patient as well. So what my job as a referring dentist, as a specialist getting referrals from my colleagues, is that I have to make that decision on each and every patient before I suggest one option versus the other. The things I look at are obviously the health of the patient, how the extent of the subgingival caries, is it how far beyond the CEJ, how close to the alveolar structure, is the tooth endodontically involved? What are the adjacent teeth and what restorative and risk factors do we have there? And even in this posterior case, you can see in the mandible, there's some altered passive eruption here. And as we get into the upper, you can see that there's quite a bit of thick phenotype. And this would be, in my opinion, considered a mild form of altered passive eruption. So this has to do with the whole quadrant then, as to, do I just crown lengthen the tooth itself, or do we actually do flap surgery for the rest of the geography in the area so that we don't get periodontal inflammation down the road as well, which this patient already has, and thus he has recurrent caries in the first place. After crown lengthening, what is the remaining crown to root ratio if that patient goes this route? Is it compromised? Is it 1-to-1, 3-to-1, 5-to-1, or is it less than that? Obviously, in today's legal world, we must provide all the alternatives for the patient. And definitely from our point of view, we must provide the cost benefit ratio of, okay, if the cost of replacing the tooth is almost the same as crown lengthening, do we still save the patient's tooth? Because at the end of the day, they'll have an implant versus their own natural tooth. And after thousands, I feel, of periimplantitis cases I've seen over the years, I would still put more money into that patient's tooth than I would an implant. And I wouldn't have said that 10 years ago. And finally, is there any other periodontal inflammation, any other risk factors in the mouth? And the most important thing is how much biologic width do I need for the restorative dentist to do their job correctly? This is a very, and one of many, many papers out there that give you a template as to, depending upon the pocket depth, the quantity of keratinized tissue, the presence of any altered passive eruption, and gives you a template of, do I just remove tissue? Do I just remove bone and apically position, or do I need to do both? And we won't discuss this today, but forced eruption orthodontically is also an option for the patient. And I've done this in a handful of times with my orthodontic and restorative colleagues. It's not necessarily for everybody, and often the patient, if they choose to keep their tooth, are not wanting to go through that time frame of treatment that forced eruption takes. But again, every human being is different, and every case is different. So because I'm in the gum business, I am quite sensitized to the phenotype of the patient. I take this into account as the number one factor outside of systemic health and the periodontal inflammation that the patient may have. We have a couple of, papers that are describing thick versus thin phenotype. I don't think I'm aware of anything more detailed than probe transparency and clinical judgment and decision of thick phenotype is bigger than 1.5 millimeters, and thin phenotype is less than 1.5 millimeters. I think it's very hard to do data and studies on this, but certainly the field is ripe for that. I'm not sure how it would be done, but it'd be interesting. So as far as comparing a simple premolar crown lengthening of a thick phenotype patient versus a thin phenotype patient, in this situation, you can see that there is a fracture, which is not as like a vertical root fracture, for example, is more of an oblique fracture. You can see here there is like an MODBL or something like that. That happened to be there. There is minimal retentive structure available, so the restorative dentist needs some room. In this situation with laser, I mainly did soft tissue crown lengthening, mainly osseous on the palatal aspect, and lo and behold, a very decent and expected result because the patient had quite a robust gingival phenotype and very little, morbidity, etc. From beginning to end, it was about 3 to 4 weeks, I believe, for the patient, and we'll discuss timelines as we go along. In the exact same tooth, in a patient with thin phenotype, I had to apically position the flap because I did not have that robustness of keratinized tissue to just do a gingivectomy. It was not possible in order to maintain as much keratinized tissue as possible for the patient. You can see here that the first molar has almost no keratinized tissue, and our mucogingival junction is pretty close to the gingival margin. So not only did I have to apically position the flap, but also conduct a little bit of osseous as well. You can see the final result here. The one thing that I always look for is where is the mucogingival junction? And you can see here that we haven't lost a whole lot as far as pre or post surgery. And in fact, in the molar area, we've gained some because we took away the inflammation and dysbiotic local factors in that area and basically cleaned up the region. So this is our key to maintain that keratinized tissue. We, as Cohen has told us, since 1962, we have been aware of the importance of this. So I'm not going to berate the fact that how important the biologic width is to the foundation of the tooth when we're trying to do any restorative or even orthodontics, and we're positioning teeth buccally, apically, even more coronally. The bone and the gum do not follow the tooth like on a textbook. Sometimes the gingiva follows, sometimes it doesn't. Sometimes the bone follows, sometimes it doesn't. So there's a number of papers out there to show you how important and critical the biologic width is, because if we do not maintain it, basically you're going to get periodontal inflammation with crown lengthening. You can get a nice healthy biologic width. Otherwise, you're going to have some tooth loss, inflammation chronically. And this is just dentistry 101 for my undergraduate students there. So let's look at a couple of cases of risk factors that we must look at. In a case such as this, the next three cases have been referred to me for implant placement. And what I would like to show you is why the referring dentist may have been frustrated with obviously placing or replacing the crown on this second molar. You can see here access is pretty tough. You can have a lot of macroglossia as far as doing surgery or crown preps in the most distal part of the mouth. We have some really tough patients. We all know that sometimes it happens on a Friday afternoon, or sometimes it happens on a Monday morning, and it gets to be very frustrating for our staff as well to really do pumping some iron in order to retract that tongue and muscular tissue as well. So this is not an easy area to work with. There are some recurrent caries in here. The patient is difficult. The osseous structure, you can see there's quite a bit of exostoses in this area. So this patient is also a bruxer. So there's fracture, is potentially a retreatment of the endo that is there, because you can see the caries is extending potentially into the pulp chambers. And then how much crown root ratio are we going to have after doing our osseous removal as well? So, where the cost factors come into play, we have to discuss that with the patient. But if you see here, I mean, this patient has a robust root length. So I feel that the predictability of conducting crown lengthening and having a retentive restorative option for the patient is very good. So that was the treatment plan. It was not extraction, socket preservation, implant, etc. What makes crown lengthening challenging will be doubly more so for the patient if you're trying to place an implant, do extractions, etc. So it's not just slam dunk, obviously. In this kind of situation, quite similar, where we have some recurrent caries, we also need to look at the adjacent crown, that if we're going to be doing crown lengthening here and trying to save this tooth, does this tooth also have some absent or radiographically absent signs and symptoms? But I also found recurrent caries right around the lingual of the first molar as well. So when we get into a surgical area, we need to assess, I feel, the whole quadrant, or at least the whole sextant. We have to look at all the neighborhood and decide again what furcation involvement is there, the extent of caries, is it right into the pulp tissue, and then the crown root ratio that is remaining as well. Just touching on the idea that a question came from one of my students last term was, if we do crown lengthening, are we not going to be exposing the furcation? And certainly a very, very appropriate question in like a situation like this. This is from Danny Melker's paper in 2001. And he obviously is known for his biomimetic dentistry and being very mindful and detail oriented in not only his post and core buildups and being very mindful of the periodontium, but his surgeon partner as well will do something called biologic shaping, as opposed to crown lengthening in the definition we discussed earlier, where we actually flute the furcal area so that it does not become a high risk area for recurrent caries or periodontal issues. So certainly, a few of my patients have had this over the years, and I just completed this socket preservation the other day. And we are planning for an implant in this region. But if you notice, a bridge that was placed about 15 to 18 years ago, and today, if the crown prep is done with that biologic shaping in mind, we certainly have a more conducive area for plaque maintenance and hygiene by the patient, et cetera. So something to really keep in mind, that this is the way we're going as far as the conservative methodology of osseous surgery, to make it more palatable for us as dentists and much more palatable for the patient as well, when we're not doing like full on osseous surgery in the old fashioned terminology there. Finally, this patient has been referred for an implant replacement of tooth number 9. And you can certainly see here why the argument can be made for an implant replacement. The things that I've already discussed, where the gingival margins are of concern. This tooth, this area was traumatized, I believe about 20 years ago. So the patients got good life out of these restorative crowns, but now tooth number 9 certainly is got a little bit of super eruption. Her occlusion is an issue as far as parafunction goes. So in this kind of situation, I definitely would consider an implant, simply to even out the gingival margins and have a bit more predictability, as opposed to just crown lengthening, so to speak, and creating the proper ferrule. So it's something to be balanced and discussed every patient that is coming across your doorstep. Now, I'm not saying that I don't do implant therapy. There's many reasons why teeth have to be lost. This is not the topic for it, but there's many amazing things that can be done with implant replacement for patients. And we all know that if we've been in the trenches for a while. But today, I think if we can just keep to the idea of, if the patient's tooth can be saved, even if it costs a little bit more, that's my mindset that I would like to discuss with you with respect to this afternoon's talk. So we got into the business of saving people's teeth, helping them keep their oral health, and really what Mother Nature gave them is organically the best, unless we can tremendously improve on it, which we have not yet done, but we will, I'm sure, get there, but maybe not in my lifetime. So from a tooling point of view, to get to the meat and potatoes of why we are considering an alternative to traditional periodontal and dental tools and equipment, is the photograph on the left is actually a photograph of tools taken from the Vatican archives in the 17th century. And the setup on the right is a typical oral surgery extraction setup when I was on the clinic floor just last term. I don't see much difference, except maybe in the metallurgy and a little bit of the sizing. There are micro periotomes, there are micro needle drivers, etc. But in general, our tooling has not changed in hundreds of years. And it's just mind-boggling that we haven't been able to change that. And the fact that I always pick up my laser first to extract a tooth means that I have implemented it in all sorts of my life, professional life. So, and the reason I've implemented the laser is that my patients gave me feedback. The more I use the laser, the more I saw that they complained less. They needed less drugs for pain control. They complained less as far as postoperative swelling, discomfort, etc. So it was mainly like a feedback system. And then more recently, I actually, even this paper from 2014, I only recently came across it about 5 years ago. And it's in the anesthesiology journal. And basically, when we use mechanical instrumentation, whether it's a drill or anything else mechanical that we use in the mouth, which is almost everything, um, the the body's response to trauma, which is mechanical, is an inflammatory response. So if we have infection in the body, we know that there's an inflammatory response that's induced. But if we also use mechanical tools in the office, it also has an inflammatory response. So is it the treatment or the diagnosis that is worse? And if you also have lasers and are using them in your office, you know this. This is a no-brainer. But the fact that finally, even in medicine, people are realizing that everything mechanical is traumatic to the patient, we need to rethink what we do in dentistry as well. And it's coming. So this little video is about a minute and a bit long. And this is the way I traditionally was trained to do osseous surgery. We first do gingival discard to the level that we want the gingival margin to live, allowing for biologic width. This is, as you can see, a fairly thick phenotype because obviously it's on the palatal, but even on the buccal, he does have thick phenotype. And step by step, we have blades to do our initial incisions. Obviously, this is the average amount of bleeding. Um, we have mechanical tools to remove the excess tissue and the deeper granulation tissue. We may need to top up our anesthetic a little bit for hemostasis. And there is a fair bit of discard in this situation to get at the recurrent caries that exist because these crowns are to be replaced. And once I fully have the area flapped, then we will start with our drills. And you can see here that once we have this elevated, that's when I would start with my handpiece. So that is the traditional osseous flap surgery for crown lengthening or even periodontal flap surgery. It seems to be unpalatable for the undergrad student when it's demonstrated, and depending upon the time available in the graduate clinic, it can take anywhere from 1.5 hours to 3 hours plus kind of thing. So this is a marathon for the patient. This is a case where I was doing crown lengthening with laser. And this is the Biolase, and this is just your typical MZ5 tip. This is your go-to tip for everything. I'm not going to discuss the logistics of which tip and what. I am basically doing a sulcular incision, which I will also be doing an inner flap discard of the granulation tissue here. And this is the finesse of the gingival margin. So please, obviously, note the amount of bleeding is minimal. The amount of tissue removal in this case, we're not considering apples to oranges, but certainly the amount of tissue removal was less and involved a lot less trauma, mechanical trauma for the patient. And this is just cleaning up the interproximal granulation tissue to get at the interproximal areas for osseous removal there. I'm going to move quickly to the next step, which is a different patient, but the exact same area. The tip is different, but that does not make a difference. This is exactly where I am doing osseous removal of the bone structure in 3D. I'm removing the buccal aspect, so flap drape is passive. Removing the interproximal, excuse me, removing the interproximal tissue and the granulation tissue so that we are able to get right at the extent of the caries that is located interproximally. Again, please note the difference in bleeding, but also the texture of the alveolar structure. It is not smooth like a handpiece would give us, and it is exposing all the canaliculi of the cancellous bone, which is bringing blood, which brings healing. Okay, and so the difference is that there is no bone slurry that fills up the canaliculi of the cancellous bone to prevent healing and regeneration of the site. So when we talk about the difference between traditional techniques and laser technique, the number one thing that I find is I have finesse and control in every type of situation. There is not a point in time that unless the patient whips their hand up at me and, grabs my hand for any bizarre reason, there is no point in time that I'm worried about the safety of the patient. Even in the most distal retromolar areas of the lower mandible, the worst the patient can do is bite the laser and break the quartz tip. There is no drill that will go through and create damage and risk and paresthesia and all sorts of terrible things that have happened. And I have seen it, and I'm sure you have as well. It's definitely less traumatic on the tissues and is minimally invasive. Because we create less trauma and less inflammation, there is less rebound and relapse of the gingival margins and the alveolar structures. As a result, it does not take 6 months or 4 months for a maxillary anterior region to heal or a posterior region to heal. It is within 4 weeks that the patient is getting their restorative. And that is all for the benefit of the patient. They don't have to wait forever and ever, which is what they feel that sometimes, in the old days is what I would do. Uh, um, what are the factors? It sounds too good to be true. And it kind of is, because there's a number of factors that do play a role as to why lasers have not got the penetration in the dental market. And number one is we dentists, we don't like change. We have a very rigid mindset. The way we are trained is the way we're going to die doing it. And it is very difficult to change someone's mind once they've been practicing 5, 10, 15, 25 years. The laser has a learning curve. You must, we went to dental school for 4 years to learn how to do a simple class 1 amalgam and a few other things, of course. But there is a learning curve involved. And just because you have a DDS or a DMD behind your name does not entitle you to pick up a laser and know how it works just because you took the course. There is finesse involved. There is a change in mindset as to how the laser is moving on the tissue. It doesn't move like a handpiece. And so this has to be unlearned and relearned again. And all this takes time, it takes patience, and it takes that mindset change. And of course, cost. It costs money to buy a machine. It costs money to take the training. It costs time and production in your office to learn it. But I'll tell you something, my production has not changed at all from the old way to the new way. And in fact, it's improved because I've implemented laser techniques, but that didn't happen overnight. So that's one thing that we need to kind of get around us. Why does the laser work so well? Well, basically, it removes 5 to 10 cell layers at a time, whereas a dental drill removes 3 to 5 millimeters of material, hard tissue material at a time. The scalpel is somewhere in between. The electrosurge just burns things, and the diode has less finesse than an all tissue laser. So in my mind, it is considered a digital eraser. I'm not drilling the bone away, I'm evaporating the bone away. And if you have this analogy of an iceberg, it works at 3 levels. Number one is at the surface level. As I said, it's 25 microns of tissue removal, evaporation, which is the top part of the iceberg. That's what I can see is happening under my loops. Secondly, it penetrates the surface, which is right at the depth of 2.5 microns. And that is where the capillaries are living, not the vessels. The capillaries are living here. And this is why you see a lot more hemostasis per se, because we are not cutting into vasculature. And in the first video where you saw me using my blade, this is exactly what we are doing. And the third is the infrared photobiomodulation, which is the low-level laser therapy, which every laser has, but to a lesser extent in the complicated. But anyways, the depth of penetration occurs at lower levels, and that's why the healing is faster as well at the ATP level and the mitochondrial turnover, et cetera, et cetera. So this is the quick and dirty of why the laser is so beneficial for patients in my office. And I'm going to now take you through one case that I have done from beginning to end. The pros was just put on, so it may look a little raw, but that was just because of impressions, et cetera. But from beginning to end, 4 weeks. This patient was referred for crown lengthening by one of my good referring dentists. The molar had fractured on the lingual aspect. The patient had some minor altered passive eruption. You can see here that the rolled margin on the lingual aspect of the first molar and the rolled aspect on the buccal aspect of the first molar must give us indication that something is not perfect underneath. You can see the halo of inflammation due to food accumulation and the dysbiotic biofilm there. And of course, now food impaction is happening interproximally as well. Radiographically, you can see here that there is quite an osseous volume on the distal aspect of the molar that needs to be dealt with. You can see the distance that the biologic width exists right now. And if we were to get right beyond that, you can then understand how much volume of space we need to create that biologic width that the patient's restorative will entail. A little bit of a hint that the margin is slightly open on the first molar, and this may have to do with cementation. It may have to do with some recurrent caries or both. So the first step, in traditional dentistry, we would use a scalpel to either create a discard, we call it the ledge and wedge, of how much room that we need to create in order to apically position the tissue, or rather in the laser world, I take no discard from the beginning. I want to maintain all volume of keratinized tissue right from the get-go. And once I'm able to see the extent of the caries and the position of the alveolar bone, then only do I decide how much discard, if at all, I need it. Obviously, I've got very little volume of keratinized tissue on the buccal, so we are not taking a discard here at all. And my first incision is right at the crest. And that crestal incision will give us this kind of ruffled border. What this is evaporated epithelial cells. As the temperature in the epithelial cell increases, the cell explodes. And as it explodes, half will go internally and half will go externally. And what you see is this ruffled epithelial border. What you see right here where my mouse is, that is the connective tissue. And so you literally have the finesse to leave the connective tissue if you want initially and just make an incision at the crest. The movement of the laser is not even like a scalpel. It is a sweeping motion. We are, in fact, conducting a symphony. We are going back and forth with the laser in order for the water to sweep like a power washer and move apically as we're sweeping down. With magnification, you have such control that you can see each cell literally exploding. Next step is that as you go deeper, I've removed the connective tissue here now, but as you go deeper, you will see that the flap will actually fall away from the tooth. What happens then is with your magnification, you can see the alveolar structure. As you see the alveolar structure, you don't have to lift the flap like in traditional osseous surgery past the mucogingival junction yet. You are able to just view that attachment right at the mucogingival junction. And that is very key for the longevity of, the retention of the gingival margin. If we can keep the gingival margin nice and stable by maintaining the mucogingival line at the alveolus, that would make the most stable long-term attachment. Often you will see these enamel projections where you have a fault in Mother Nature's manufacturing of enamel, and this often will cause periodontal pocketing and caries issues. So something definitely to keep your eye on and to deal with when you're doing your osseous, because with your laser you can also remove enamel, but you can use a handpiece as well if you wish to do so. So as the flap falls away from the alveolar structure, you can see how the laser has also created that ruffled surface, not like a handpiece, on the alveolus and the mandibular bone as we are lifting. And once we lift, then you're able to see the interproximal tissue. You're able to see and remove it. You're able to see the extent of caries, and then you're able to identify how much of the bony structure that you're going to be removing. Please note that the first molar, now we can understand why there was some rolled inflammatory gingival tissue on the buccal aspect of it. There's absolutely no biologic width here, and in fact, there's imposition of the crown into the furcal space. This is completely not biologic shaping, according to Danny Malkar. As this photo shows, I'm actually doing some osseous removal at 90 degrees to the tooth. This could never happen if you had a round burr, a periodontal burr, or any end cutting burr. It is too dangerous to actually lay your laser tip on the soft tissue and aim the laser towards the alveolar structure in order to create flow and fluidity of the mandibular bone so that the flap will sit passively. I can only do this with the laser because there's safety. The only part that is removing tissue is the water that is touching the bone. I can control where that water spray goes with 25 microns of control. Incredible. Let's move to the lingual. Remember, on the buccal, we didn't want to remove any keratinized tissue because there was very minimal zone to begin with. So all we were doing on the buccal was going to apically position things. Whereas on the lingual, there is ample keratinized tissue, and B, we need to create some harmony of the architecture around the second molar flowing into the first molar. There is also a deficiency, as you'll see in the next photo, on the first molar, so a discard was necessary. This little bit of discard, this is less than a millimeter, I was able to conduct simply by placing the laser and sculpting the tissue out. I have that much control in a very movable tissue flap. That's the finesse that I'm talking about. You can see here the deficiency of the crown cementation or the crown prep or both that we were talking about. And certainly there was not enough biologic width to create a nice flowing ferrule and crown adaptation. So eventually something will need to be done here, maybe not, but there is recurrent caries starting on the mesial, or sorry, the distal aspect of the first molar. So I want to expose that for the dentist so the patient can either clean properly now, or the dentist can have access to redoing the crown potentially, but at least the patient will not have to have a second surgery because the whole area has to flow. You can't just do a peephole crown lengthening on just one tooth and leave this as is. It doesn't, the tissue doesn't sit right, and then the gingival margins are poorly adapted there and therefore will not be stable. You must get that stability we were talking about. And again, another little bit of sculpting of the papilla so that it can sit ever so perfectly. I would never take a scalpel and try to remove this much tissue. I just do not have that malleability of a blade to do something quite so beautiful and sculptured. Finally, if I wanted to conduct osseous on the lingual aspect, and in this case, of course, we're needing to sculpt the architecture of the mandible here as well, I can come at it at 90 degrees and have the safety that we need to. The distal wedge is done in exactly the same way where I can get access to that ridge of tissue, that osseous tissue that you saw on the previous X-ray on the first slide. We also know that on the lingual aspect in the retromolar area, the bone, the mandible can be quite cortical and quite difficult to access. If you were to use a handpiece back here after lifting this flap, you'd literally have to lift the flap way off in order to get access to drilling this down. Whereas literally I can take my laser tip and sneak under and create a beautiful flowing osseous structure here without even having to raise a flap. I can actually core out the bone in this situation right here without even lifting the flap. I can literally cut the bone away from the tissue, leaving the tissue intact. That's how much safety I have. You can see it's sort of deceiving when you flap the area versus the actual clinical photo. It doesn't help signify how much of a ledge in that distal lingual area actually exists. So anyways, here I am. You've seen I've cored all this out. I'm just finessing up the margins of all these little peaks and valleys of osseous removal and now creating the proper biologic width on not only this area, which has already been done, but now also on the first molar as well. Now, this may upset our ADDH on dental personalities where we don't have a beautiful, smooth architecture of the bone. But keep in mind, when we use a handpiece, we keep all this osseous sludge that plugs up these canaliculi and slows down the healing. And then it's the body's responsibility to remove that and then to regenerate. And that will also keep the area from healing quickly and getting to the final step of restorative as well. Once the area has been deossified the way we want it to be, and we've removed all osseous, all granulation tissue tags, you will actually see the blood start coming in very slowly, like a seeping little trickle. And please note, the look of a blood clot is different in a laser raised flap versus a traditionally raised flap. This blood clot here is actually stable. The blood clot adheres to a root surface or any surface without biofilm. When every part of the tooth, the bone, and the soft tissue is touched only with laser, there is no biofilm left. Whether it's on the inner flap, whether it's the root surface, whether it's the osseous structure itself, it is degranulated to the best of our ability, and only the stable blood clot will tell you physiologically that this blood clot is stable in order for us to identify that there is no granulation tissue or biofilm left. If I happen to have, some calculus here that I quickly want to go in with a Cavitron, I can do that, but then I'll follow it up with a laser afterwards. You can see here, it's not oozing, it's not pussing, it's not seeping blood. This is a stable flap. It is sitting passively, and there is lots of room for my referring dentist now to address the crown prep. Suturing up on the buccal, I want to maintain this. Yes, it's sitting basically at whatever level that it's going to close in on. I'm not worried because I know that the osseous structure will dictate where the gingival margin will sit, and that is where the body is the most happiest. And I've created that foundation for the teeth in this area. Lingually, you can see there's lots of room now, and the patient's tongue will not be an issue because the dentist can see and there's no struggle. My job is to create less struggle for everybody, including myself. This is 10 days, food impaction, obviously, but please note the tissues. This is almost like biologic shaping. I did also adjust the furcation area a little bit here so that the tissue is sitting flush. This is all new connective tissue. All this is new connective tissue. This does not happen with a blade and a drill. Connective tissue is going to heal only when it's happy. Regeneration only happens when it's happy, not when there is inflammatory tissue, biofilm, or any other, dysbiotic factors that are playing a role here. Obviously, it's tough to keep this clean, but the patient was only applying chlorhexidine by Q-tip in this area and now can begin brushing and flossing. This is 4 weeks later. And this was just 2 days ago, actually. So you can see here before and after where the gingival margin is sitting. And this collar of keratinized tissue still exists. And on the lingual, before and after. And again, new connective tissue is sitting here, and flossing and brushing needs to start happening now. This would again never happen unless the tissue had totally healed the way we want it to. Okay, so I think we're coming on exactly 2 minutes to go. I have, I think, covered everything that we set our goal to today. I hope I have revitalized your interest in salvaging teeth and keeping them for the patient as opposed to just defaulting to extraction, implants, etc. I hopefully have demystified the laser for functional crown lengthening for you. And hopefully I've also created some interest in trying to implement this minimally invasive methodology for our patients. For me, it's a no-brainer. I've come to learn that, there's very little in Perio that I do that, people pat me on the back for. We are basically the blood and guts of dentistry still. But when patients leave with their crowns and their teeth, and they are basically just kind of, gone in for a tune-up and come out, it's much more satisfying to me as a clinician. So hopefully you feel the same way. Anyways, thanks for your time. And I think we're going to do some questioning. Is that right?
Yes, thank you, Dr. Preety. We can take a few questions if anyone wants to reach out. I think we have some in the chat. can we do crown lengthening with Biolase?
That's exactly what we talked about.
Yes. Here's another one, Dr. Pretty. Would you comment on intracellular crown lengthening with no flap to create proper biologic width around a fractured tooth?
Again, that template, if I can scroll to it here, will tell you exactly if you can do that. Depends on the case right here. And you can refer to this article. It all depends on the amount of keratinized tissue, where the bone is, and where that fracture is, and where your prep is going to be. So yes and no.
Great. Dr. Pretty, that was awesome. I hopped on a little bit late. Just so everyone knows, my name is Antone. I am the California and Hawaii Senior Territory Rep. And I would suggest if anyone is more interested or wants to have some more questions or just interested in maybe a virtual or a demo, they can reach out to biolase.com and actually hit on a demo link. And that will actually get you to your right proper territory rep. So thank you everybody for taking some time and listening to Dr. Pretty's wonderful, or at least the half hour that I heard, wonderful presentation. It was awesome. And if there are any other questions, you guys can go to biolase.com. But I do appreciate everyone's time. And Dr. Pretty, thank you very much. It was good from what I heard, and I appreciate your time as well and your passion and love for lasers. So thank you very much.
Thank you very much and the opportunity. Have a good weekend all.
Okay, thank you everybody. Have a good weekend.
Bye.